And my next 30 minutes will talk about this complex calcified lesion in chip patients. And I'm very happy to see a lot of familiar faces and a lot of new faces. What I'll put it together is the definition of a chip case and a calcific lesions, prevalence, prognosis, short and long-term outcomes, our current treatment strategies and future direction. I'll give some theory and then show a few cases. So basically, what are we talking about? Chip basically is not only the complex lesion, it is the patient itself. Patient has a lot of comorbidities, like shown heart failure, diabetes, kidney dysfunction, advanced age, and then the CAD, which is more complex, multivessel, calcific lesions, left main. Then hemodynamic, those who are in heart failure, borderline ejection fraction low, whether it's a 30 or 40 or below, and borderline hemodynamic, blood pressure is 70, 80. So those cases constitute to all what we call chip. And clearly, you need to decide that does the patient really need intervention? So it's one is a suitable patient to identify, and many of those cases are surgical turn down. And as you know, when surgical turn down, we are it. If we have some complications, beautiful case shown, when perforation sealed, need surgery, surgeons won't touch it because they already have turned down. And there are actually a lot of registry data coming that we can do good job, even in those complex surgically turned down cases. And of course, then comes that you have approach of within our institution that how you are going to take care of those patients based on the ischemia. So multivessel disease, most of these patients have multivessel, calcific, occluded vessels, and also have a simultaneously LV dysfunction. So then decision comes down, do you do culprit vessel, one vessel, area which is showing ischemia, and we know that latest trial, Revive 2 showed that our interventional point of view in a 4 or 5 year time did not show much difference, but we are trying to figure out what exactly happened in the trial. And then the key is not uncommon in these complex cases, you do the important vessels at one point. Don't try to do, be a hero that you have opened all the vessels. Some could be staged at the later date. Why? Because anytime you do complex intervention, it causes ischemia. And of course, you need a support in many of these cases with LV dysfunction or even in some normal LV function. Complex bifurcation, left main, which you have done, right corner either occluded or very diseased, and now you want to do an intervention, EF may be normal. But that person can get into trouble with a slow flow. So you need to be fully prepared. Then finally, that once we are done, our job is not over. We need to make sure that patient has a proper follow-up. And the biggest thing for us is that patient going to take a DAPT. So all this intervention, complex intervention, we can do good. But if patient is not taking DAPT or have a bleeding, that's a very important factor which causes the interruption of the DAPT. So that will create a subsequent poor outcome after even excellent work which we have done. And of course, we need to compare, continue our CAD risk modification. To say, well, how do we identify what are the criteria that of every patient has so much complexity? I showed from the disease point of view, hemodynamic point of view, and of course, angiographic point of view, what are the really things which we should think about? There's a very nice paper from British Society, Cardiovascular Society database defining PCI in complexity and high risk. So all the factors they took care, including, of the 80 factors, which kind of common, and came up with basically 13 factors. In the age, more than 80, female sex, previous stroke, MI, PVD, low EF, and chronic kidney disease. Then, in the procedure point of view, you need calcific lesion, although they didn't call it calcific, it used a rotational atherectomy, left main PCI, 3-vessel PCI, arterial access, you have to, and a plan, LV mechanical support, and long lesion length. And they made a CHIP score, LV mechanical support, if you use 3, chronic renal failure 2, and remaining factors are 1 point. So what they did basically, many of our patients have multiple risk factors, but by and large, usually 3 factors are present, and based on the presence of these risk factors. So 7 in the patient factor, 6 in the procedural factors, you come up with a CHIP score of low risk, intermediate, and high. And this is the event, Mackey in hospital, 30 days. So low risk event rate will be about 5%. Your intermediate 7 to 10 CHIP score, event rate will be about 12, 13%. You go beyond 10, it's about 20%. So at least you can streamline patient subsequent management, that what we need to do. Patients who have high risk of, with a high CHIP score, you'd want to be more aggressive. As I mentioned, that even with a normal ejection fraction, many times we put a balloon pump, Impala. Assist device also, assist device itself puts into the CHIP score. But key is that those patients need to be planned better to come up with better results, as shown here in this CHIP, very nice demonstration of our working algorithm. Then, how do we manage the patient? So I have put it this A cube, that we need to do three things. One, assess the lesion by angio, IVUS, OCT. With borderline cases, or sometime you need to decide whether we need to do atherectomy or so. So you can decide based on the imaging. And then alter the lesion. Alteration basically means, simple case, we do a balloon, cutting balloon or so, high pressure and put a stent. But in many of these cases, particularly calcific, diffuse, CTO, bifurcation, we do a plaque modification, not a debulking, plaque modification, and many of the plaque modification devices which we'll talk about, and then after it is done, then you assess by imaging. So I am actually very big proponent of the ultimate, that is the IVUS in the end of the case. Pre you can do, of course, many times it's very difficult to advance the catheter. When we say your IVUS catheter doesn't go, means patient is a calcific lesion. So what really need is, most important is the post apposition, that you had done, good job, stent is fully expanded, and then, as I mentioned, that in the CHIP, it's not only the lesion, you have to think about the LV dysfunction. And that is use of LV assist devices, whether with the Impala, PT we rarely use it, Impala is available now, here also, although very expensive, but patient with especially in the low ejection fraction. In the simple cases, based on your practice, whether you stand alone with a balloon and stent, 2/3 of cases, there you are talking about high success rate, low TLR, lower bleed. The issue comes in the complex cases. What we learned in the past, we used to give more strong antiplatelet therapy in these patients, and to result, major bleeding. And major bleeding created more trouble at downstream. So clearly we need to be cognizant about, don't use too much antiplatelet therapy, like 2B3A use have gone down significantly, because we learned it may help us initially, but create more trouble at the future. So lower bleed, lower procedure complication, whether lower TLR, that need to be seen. So this is basically our therapeutic rationale for treating these complex diseases, disease process. So LV assist device, as I mentioned, balloon pump, PTV, and Impala. And this is our another algorithm which we use, basically based on the EF. Used to be 35, but now there's a new trial going on, Protect 4, with the EF cutoff is 40. Basically, the CHIP patient is in this group. Low ejection fraction, complex PCI, high syntax score, high STS, and you need extensive revascularization. If it's a simple case, as we mentioned here, the normal EF, you probably can just do balloon, or maybe rare cases, you might need Impala, even if it's a complex PCI with a normal EF. And that case will be a classical case of right coronary involvement along with left main, because they can get sour rapidly, and you need to be prepared properly. Then, of course, very severe ejection fraction, you always need to have some assist device, but this is where the Impala comes in. And of course, a lot of people decide based on the EDP and patient hemodynamic, whether use or not, or balloon pump, Impala, both are available. At Sinai, we use about 5 balloon pump and about 15 Impala per month of the 350 PCIs per year we have done, per month we have done last year. Now, imaging. We learned imaging adds to understanding the lesion. If you are not sure, imaging pre, yes. Post, I mentioned, very, very important, very vital. I'm still surprised that the latest guidelines didn't make imaging as a class 1, even in the left main of cases, but enough data, but probably the next reiteration of the guideline will make imaging as a class 1 indication. It still remain 2A and 2B. And of course, in the borderline cases, you decide need to intervene or not based on the physiological testing of FFR and IFR. We actually have a very nice app. I'll show you all in the end. Dr. Keeney, who will be doing the live case later tonight, is showing there, cardiologyapp.com. All the devices which are available, we have put in any, start from the vascular closure device to the ultimate Impala. So everything is in this cardiologyapp.com device aid, because we have a lot of the apps in there. So device aid really puts into together all the categories of the balloon, stent, wires, everything is there in your armamentarium and available on the iPhone or iPad and any of these devices, handheld devices. So basically, the calcium need is increasing. Why it is increasing? Because of diabetes, age, renal failure, hypertension, smoker, and of course now elderly population. Patient coming for tower needs CAD. Most of them have very calcific disease. So calcium use is continued to increase now, particularly over last 10 plus years. And overall, if you take all the studies, the moderate to severe calcium is present in about 22 to 30% of cases, roughly about 25%. The lesions which we intervene are moderate to severe calcium. Now, just to give this data from the United States, 8 to 10% lesions are severely calcified. Atherectomy number is still about 5%. So even in the severe calcific lesion, this is prior to the data of the IVL, that only half of them undergo atherectomy. So these are the NCDR data, as you can see here, that about 5%, the market point of view, it's about 60% rota, 40% orbital, and 1 to 2% laser being done at present in United States, as shown here. Now, I did the trial called MACE, about 300 plus patient trial, 350, and asked the operators to use the device based on the lesion. And what we learned is that even in the severe calcium, this is about 2015, 16, 17, that even severe calcium, atherectomy was used only in 1/3 for various regions, but this is what the practice. This again, I mentioned, orbital was not part of it, and IVL was not part of this trial. Now, then question comes, you have said, well, calcific lesion. What does the calcific means? One is our ACC-AHA classification of the lesions. Severe calcium is tram track sign on angio. As you can see here, you probably don't need any imaging. Some will say, well, maybe it's a superficial calcium. But once you have this kind of tram track, it's not a superficial calcium. It's clearly our deep calcium. And then IVUS, based on the shadow, that there's nothing behind the echogenic area. So that is, we said more than 2 quadrant makes it a severe calcium. And OCT shows you very demarcated nodule, the area of the calcium. And this actually OCT is helpful because it can quantify the degree of calcium and what breakage and we do after atherectomy or after IVL. Now, why calcium is problem? We all know that you cannot deliver the device, stent will not expand and will not oppose, clearly more dissection. So all more trouble of stent thrombosis, higher ISR and malopposition. Arc of calcium increasing, decreased stent expansion have been shown repeatedly. Alone high pressure balloon dilatation will not be enough. As you can see here in the calcific lesion, going up to 24 atmosphere, stent expansion is still 70%. And what also has shown that irrespective of the calcium, once you use atherectomy, it will give rise to a better stent expansion. So those are the additional data we have in treatment of these cases. And of course, we have both IVUS data of the categorizing the calcium with the numbers from 1 to 4, as well as and have a optimization expansion, and same is the OCT-based calcium score, which comes out actually, this is being used now in many of the trials. Calcific trials like Exit Calcium latest, they took the patients, those who have a OCT-based calcium score of 4. So based on the calcium angle, calcium thickness, calcium length, you come up with the 0 to 4 points because subsequent stent expansion is dependent on the calcium score. Now, calcification, besides having acute problem, what has come in last few years also have a outcome at the long term. And this is our data that increasing calcium from mild, moderate, severe has a gradient of worse outcome as shown here. Similar data from the Acuity and Horizons trial that going from none to mild calcium to severe calcium, all the event rate increases. So clearly, calcium is not a trouble only at time 0, even subsequently. The MACE study which I showed, we actually have same mild, moderate and severe calcium, and if you can see in the violet bar, the lesion success and MACE is all in the severe calcium. So in this day and age, what we need to worry about the severe calcium, not mild, moderate calcium. Very, very important observation, which or conclusion we got from the MACE trial. The syntaxes, 10-year follow-up showed that patients who have calcific lesion, as you can see here, had almost 1.5 times event rate, 22 versus mortality 36.4. And you can say whether the 3 vessel or left main disease, calcium increases the mortality, so bad prognosis. So clearly that even if you did intervene subsequently, the rota was used only in 3% of cases, and 30% had those calcific lesions having a bad prognosis. Now, whether you have PCI or cabbage or the we say, well, calcium may be only in PCI. No, both cabbage and PCI, calcific lesion have a bad outcome as shown by the syntax trial. Now, in addition to, so there are various factors. Why calcium, you have done a good intervention, should have bad outcome? Because it is probably a harbinger of your diffuse atherosclerosis. Classical example is those who have highly calcified lesion also bleed more because their vessels are diseased of the rest of the systemic circulation. So we have various devices which are available, balloon, NC balloon, cutting balloon, angiosculp, laser, intravascular lithotripsy, rotational atherectomy, orbital atherectomy are shown here, and I put it together. Then of course we just got the open NC balloon available in United States, which have been here, double layer balloon. Then your atherotomy, various of these scoring balloons. Then laser. Laser usually is used in uncrossable lesions. So you have your rota wire cannot go. So those cases, the laser is also used for ISR, unexpanded stents. And then truly for severe calcium is the rotational atherectomy, orbital, and shock wave intravascular lithoplasty, IVL. So 2 of them, rotational atherectomy, which has been there since 1993, and orbital atherectomy since 2013, are available. They basically have different principle. One is the diamond chips, ablate the calcific inelastic plaque, and of course it's a to and fro motion, and compared to orbital, which is not only horizontal, also in vertical, speed dependent, cause the ablation of the plaque and try to give a good, nice lumen. They have different principles, both of them, how to work, but can be used with a 6 French, and of course there is a separate, their wires have plus and minuses of the devices. Majority of the time you can interchange them, but some cases will do better with the rotational atherectomy, particularly the osteal lesions and severely calcified, because as you know, in orbital, there is no ablative surface at the tip. It's just little proximal and so. Now, RotaPro, our conventional rotational atherectomy, because they classical, they cannot make now. It all will be replaced with a RotaPro. Many of, if not all, are using the RotaPro system. Much easier, everything is at the handheld. That is the biggest advantage, rather than having any foot pedal and assessment of or the Dynaglide, all those techniques are right there. Then the guide wire of the Rota is special. Now there is a new Rota wire drive, little more floppy, more flexible, and of course use a floppy versus a support guide wire in osteal lesions, ISR and distal lesions and so. And of course it works with the, as I mentioned, differential cutting principle. We have a nice review article about atherectomy, rotational atherectomy with the various expert panel, go through various steps, including the technique, and who should do it and how to avoid various complications, which were talked about, slow flow, bud entrapment, and all those. A very extensive, detailed discussion about atherectomy techniques in this paper. Now, we also learned that if you use the rota as a bailout, try to do a balloon, very calcific lesion, balloon did not go. So use the rotational atherectomy. So this is the rotate registry that if you use the bailout rota, your complications are higher. And most of the time you do it because of device failure or device undeliverable. So clearly I would say that if you think about severely calcified, it's better to be prepared, go with the atherectomy, rotational atherectomy, and do it pre-planned rather than as a bailout. We actually have 2 trials to really show benefit of the rotational atherectomy. Rotexus trial was rotablator plus paclitaxel eluting stent versus PTCA, and basically showed that if you don't do rota, about 16% of the time, you'll have that rota regret. Something else need to be done. And rotational atherectomy did increase the procedural success, but overall 9-month follow-up was not different. Then same group investigators did a prepare calcium trial about 5 years later. This time, instead of high pressure, use a scoring balloon, angiosculp or cutting balloon. and you have a better stent or zero. And basically what we found, again 16% of the time, in a calcific lesion, operator could not get into the success of the procedure, so needed to modify. And outcomes were slightly better, although numerically was lower, but did not make a p-value significance. There was definitely lower late loss in this study. Now, orbital atherectomy works, as I mentioned, the principle of both vertical as well as horizontal axis. You slowly advance 1 millimeter per second. Actually, OA, the first data, first in men, were done in India. Orbit 1, with a 50-patient trial, was done in India, and of course, now it's going to come back. So next year, by first to second quarter, we'll have orbital atherectomy available in India. And basically, 1 millimeter per second advancement, 20 to 25 second run, 3 to 5 passes once lesion crossed. Compared to rotablation, we touch and come back. Here you can constantly go forward because it is not engaging into the lesion. And of course, it is both horizontal as well as vertical movement. The Orbit 2 trial showed great efficacy, about complication rate of about 8 to 9%, and very good outcome. One of the biggest difference, even our data which we have published, is that orbital atherectomy, subsequent TLR, is lower with the orbital compared to rotational atherectomy. Remember, rotablation, whether it's heat dependent or whatever, very high, restenosis 16-18% at follow-up, although effective device acutely. But orbital, consistently, TVR has been 8 to 10%. Now, we also showed that mechanism based on the OCT, orbital versus rotational. So what happened is orbital, because of the dual mechanism called more deep cut of the calcium, your stent expansion, malopose struts are lower with the orbital compared to rotational atherectomy. And there is a trial ongoing at present called Eclipse, 2,000 patient, orbital versus conventional angioplasty, followed by DES, and will give us a data of long-term, whether atherectomy is beneficial on long-term in these cases. Then the laser, as I mentioned, that is available now, 0.9 and 1.4 millimeter, although it's a big, the machine had to be brought to the institution, and can be done particularly for moderately calcified, uncrossable lesion, ISR, unexpanded stents. There are some studies have shown that laser does quite well in these cases, but many of them will not cross. So very calcific lesion where you think IVUS did not cross, you try to do laser will not cross also. That's where you need to do a very small rotational atherectomy. Then of course we have a new kid on the block, which has become favorite for most of us now because of ease of delivery, shockwave, it's a simple balloon-based technique, and the cycles, the technique very rapidly to learn. There is not much in terms of the learning curve, and very effective device. And thus the deep cuts, crack in the calcium had been shown by various the imaging studies of the OCT and IVUS, and the Disrupt CAD 3 of 380 plus patient trial showed overall safe, able to do, of course, many of them, you had to do a balloon before, pre-dilatation almost 55% before you put IVL, but good lumen expansion, and more importantly, very low complication. One of the things consistently has come, very low complication, particularly perforation. As you can see here, perforation is less than 1%, freedom from MACE, 92%, 1 year MACE was 2%, so overall very effective device. So let me just show you 1 or 2 cases. This is the patient presented with chest pain and has a significant ischemia in the LAD territory, and this is a classical chip case, long calcific tortuous LAD. So what we are going to do here, you're not going to go with a rotawire directly, you go with over-the-wire system, use your workhorse wire and change it to the rotawire. And then question comes that what else you need to do. This patient has other vessel disease also, right coronary, only moderate lesion in the except the RPL, good ejection fraction. And then the key is what can we do? Various technique which have been discussed, whether you use atherotomy, high pressure, atherectomy of the rota, OA or laser or shock wave, or patient goes for cabbage. Of course, anybody can go for cabbage, but such a calcific lesion. Now, you want to say, well, I want to see whether it's how it's a superficial deep calcium, I may change the strategy. I personally would say, this case has a severe calcium, your IVUS sometimes may give you in trouble. Just do the atherectomy first and then decide if you need to. So this case, we decided rotational atherectomy, we changed it to the wire, and of course our goal is stent delivery and optimal stent expansion. and here 1.5 millimeter burr, took 6 runs, went through all, and have now this result. Question comes, do you upsize the burr? Now use IVL or balloon dilatation. So very simple, right case, what I would suggest that put your workhorse wire and do a balloon. If your balloon expands it, you don't need IVL. What is the purpose of IVL? To get the stent expansion. But if you have after your atherectomy, your balloon expands, then that is good enough. So there is no reason to use any other fancy devices, then followed by stent, then post-dilate, 2 stents done in this particular case, Zions, and this was the final result. With a 1 point, such a long calcific lesion, 1.5 burr, and 2 stents. Excellent angiographic results. There is a second patient, also, this is a true chip patient. Patient has a coronary artery disease, patient has a severe aortic stenosis, low ejection fraction, and has a peripheral arterial disease. As you can see here, the multiple factors in this particular case, EF is 25%. Now what to do? Severe AS on echo. Second, so actually we could not show the iliac artery. There was some issue with the conversion from to the MAC, but there was 80% ulcerated right common iliac artery, and this is the right coronary which is totally occluded, and the left, after this very calcific aortic valve, the left sided here. This is all calcium, no intervention before. Subtotal LAD, and of course the 90+% lesion in the circumflex, as you can see here. And then we did first the balloon valvuloplasty, because you need to low ejection fraction, complex disease. So valve area increase from 0.7 to 1. You don't want to be too aggressive, because ultimately if this patient does well in next 1 or 2 months, we'll get the tower. But you need to get for the primary coronary artery disease intervention. So 18 millimeter balloon, then we cross with the microcatheter with the Gaia 3 wire, 1.75 burr, because large vessel, as you can see here. Now we have come up, stenting, and then the synergy stents were placed, and now you the circumflex, dilated each branches, and they stented the circumflex artery. Then peripheral, PTA stent of the right common. So these are the chip type of patients where you have to do all. And of course the impeller removed on the pre-close, and patient did fine subsequently. And then let me show this very complex case of the laser, rota, and IVL for complex calcified. This patient, 85-year-old, had a PCI 8 years ago, and then presented. This was my live case to one of the Brazilian society, very calcific distal left main. It doesn't look that bad, but you see the angle of the LAD, very calcific, circumflex LAD, and LAD is angulated this way. So clearly, this one will give the trouble. So very calcific, took us very tough time to advance the wire. No microcatheter will go. We tried other microcatheter, which is the fine cross. Then we use a Corsair, did not. So what you can do sometimes, your device cannot go, put a balloon into the side, anchor it, then your device can be advanced. So therefore, then we were able to advance the wire. So after the wire, because nothing were going, we use a laser to the proximal segment from left main to the LAD. Then question was, as shown earlier by Hazra, that you do shock wave of the side branch. That will open up some of the LAD calcium. So this is what did, shock wave of the side branch. And then we were able to advance the rota wire into the LAD with a 1.25 millimeter burr. Did the IVAS totally circular calcium in the entire segment in this particular case. And then with the shock wave also of the LAD, 1.25 burr plus shock wave, high pressure balloon, used additional with the Wolverine, and then finally did a mini crush stenting port and final KBI, and then confirmed on the IVAS. That's what you need. In this complex case, IVAS in the end to see the full stent expansion, and this was the final angiographic results. So excellent using all 3 techniques. The calcific nodule, lot of data have come now. Our paper, just a case report in JACC intervention, that calcific nodule, does IVL work on calcific nodule? My answer is yes. Some people believe no, that you have to shake it or only shave it, but no, you can shake. IVL will work in the calcific nodule also, which we have shown documented on the IVAS, on the OCT, and we have the ablated calcium for the calcific nodule by the rotational atherectomy. And these are the all devices which we have, the plus and minus. One of the biggest problem with IVL is not the device very effective, but the cost. tremendous cost almost 2 and 3 times of the atherectomy, but that is what it is, very useful device otherwise. Protect 4 will be, I would say, ultimate trial of answer in the chip type of case. Whether you use impella needed or you just do with a balloon pump or without balloon pump in complex cases. EF less than 40% and multi-vessel CAD, complex CAD, which a clear-cut definition. This is the trial ongoing. We are the top enroller of the 360 patients globally have been enrolled, and we have 48 patients. So just to sum up now, that how do we protocol for management of calcific lesion? So case where you have uncrossable, angulated, tortuous lesion, that IVSN will not cross, you just basically use your workhorse wire, use a atherectomy. Laser, if you cannot cross, rotawire or OA wire does not go, then laser comes in. And after that, you do balloon dilatation. If optimal, you are done. Non-optimal, you go to IVL. Now, otherwise, moderate to severe calcium, straightforward vessel, 2.5 to 4 millimeter, 70-80% lesion, it's not a 99%. I think you can assess based on the OCT and IVUS, those who are believers, need to strategize. I would just go based on the angiogram, but a lot of people will do that. If you have low calcium points, you can just do high pressure balloon dilatation. And then if not successful, not fully opens, then you go to IVL, otherwise you just put a stent. But if you have high calcium score, the points are 3, 4, 5, then those cases should go plan with your IVL. And then of course you see a subsequent good balloon expansion, and then the stent will give you the best results. So just to say, we do about 24% of our cases are atherectomy, and IVL we do now about 30 cases per month. So just to add up, we have the calcific aid, which really fits into, and now we are making a calcific aid 2, which will incorporate all those rota shock, laser shock, orbital shock cases. And so just to sum up, that all these chip patients with a calcific lesion require planning. Pre-procedure planning, getting them ready, same. High creatinine, you need to hydrate them gingerly because EF may be low. So you have pre-planning for these cases. Of course, the imaging may be needed, definitely for the post, and that is the key, that you need to have a good stent expansion. And atherectomy and IVL, many times with the device synergy, will be needed to have a good acute angiographic result, and this will subsequently translate into a better long-term outcome. And of course, think about LV assist device in low ejection fraction, because once patients start going sour on the table, it will be very tough to save them. And so I am very thankful to our people here actually in our CCC live webcast, which every third Tuesday, we have the structural and peripheral interventions, and so far have been a big hit. We get about 18,000 viewers per month, and more importantly, of the various countries, from India is just second to United States, and various in our cardiologyapps.com, anything you think about, and give some idea. So we'll make our cardiology devices very user-friendly, kind of an educational tool and learning tool, strategy-wise, when you're performing any special technique in our interventional cardiology. And thank you very much.
Thank you, Dr. Sharma. I think it was an excellent overview, especially in 2022, covering almost every aspect of it. I think the topic is open for discussion. Dr. Hazra, you'd like
a beautiful talk. The secret of Tuesday, Dr. Samin Sharma, he fasts on Tuesday. The rest of the day, he's thirsty for the knowledge and new technology, and is very eager to teach the whole world. That's the beauty of a man who has dedicated whole life on calcium complex management. Very proud of him. My question to you, sir, is there any role for pre-PCI CT scan to know the enemy better, or it is just a superfluous? And second, suppose you do the rota like in the long LED calcified, tram track calcification, severe calcification, you do the OCT now, and you demonstrate there is not much of dissections. You can just put a proximal stent. Your proximal stent was a little underexpanded. You put your all energy, all shocks, all rota efforts in the proximal LED. Rest of the LED can be managed by DEB. Is it a far-fetched thought, or it is a possibility?
Yeah, so question comes is, enough data have come now that drug-coated balloon, drug-eluting balloon, particularly in the medium-sized vessel, small to medium size, basically less than 2.75, the outcomes are equivalent to DES. Now, in these complex cases, I still have to, again, so drug-coated balloon, as you know, is not available in the United States for the coronaries. We're just starting few trials, and majority of them, 2 of the trials are still for ISR only, not for the native vessel. One of the companies making it for the native vessel, but for the ISR. So key is that can you do remaining in this complex case with the drug-coated balloon? I don't know exactly. So whether the drug-coated balloon will be answerable in those particular type of cases or not, what will be the long-term results that you just do a part of the, in complex case, you have done a plaque modification, you have put a stent is nicely open, but if there is a dissection, you have to put a stent anyway. If there is no dissection, as the case which you will say, that we did a imaging, good lumen, and probably without putting a stent, you probably will not get a lumen of 5 millimeters square. You probably will get a 4.5, while we know with a stent you can go to 6+. So key is that can you leave it alone in some cases. So I would say that I think this is a very good thought, just like having a device synergy and where to limit ourselves, because we also learn multiple long stents can give the trouble, have a high restenosis. So can we do a shorten the stent length, and some just use with a drug-coated balloon. So good concept. I don't have experience, and there's not much in the literature also in these complex cases.
Just a comment and a short question.
Yes.
The comment is, sometimes you said about decision to do mechanical circulatory support based on 2 things. One, the ejection fraction, the other is complexity of the lesion. Recently, we did a case where there is a circumflex discrete 90% lesion, which is seemingly very simple. The LAD territory was infarcted, and the ejection fraction was around 40%. So it was not that bad in LV, but it was a dominant circumflex and a straightforward lesion. And when we did the angioplasty, there was a lot of problems, no flow, etc. Fortunately, in anticipation, we had a contralateral access, so we could quickly put a balloon pump and we could salvage the situation. I just wanted to comment saying that this is a relative thing. It depends on the case essentially. That was a comment I wanted to make. And regarding the question, you spoke about the prepare calcification trial. I just want to ask you the question, for near identical results with a scoring balloon versus rotablation stenting, nearly identical results, does a rota stenting have a superior long-term outcome as compared to a scoring balloon based intervention?
Yeah, so there are actually one trial which did a balloon was followed by stenting versus a scoring balloon followed by stenting. And it seems to be this was they use a cipher sirolimus coated balloon. So there seems to be a little better lumen area expansion. And we have the latest trial also of the COPS, where they did a cutting balloon followed by regular balloon and then see the minimum stent area. And it turns out to be slightly higher, but particularly in the calcific lesion. So coming back to the point, whether you use a high pressure or cutting balloon, probably cutting balloon I would say will be a little better in a mild to moderate calcium.
Rota versus scoring balloon.
That's right. So question is only rota versus scoring balloon. I think that has, from the trial point of view, that has not been tested. The rota I would say is for severe calcium. And if you say that all these scoring balloons and cutting balloons, if you see the product label, they are actually not approved. We're doing a trial called rota cut. So the concept is rotational atherectomy with a small burr, 0.3, not 0.45, followed by cutting balloon. Or second group, rotablation, your 0.4, 0.5 burr to artery ratio, followed by high pressure balloon dilatation. 60 patient trial, we have done 47 patients already. And outcome is acute and minimum stent area. So question is whether cutting balloon will add to the rotablation, compare and use a smaller burr compared to use a regular burr and high pressure balloon dilatation. Now, that concept is still evolving. There are exit calcium trials, the latest showed high pressure balloon dilatation versus IVL, your stent expansion remain the same. So key is that whichever technique you use, if I had to say that it is not a severely calcified and you bring your cutting balloon and lesion expanded nicely, I think you don't need rotational treatment. But from trial point of view, there has been no trial to compare the cutting balloon, scoring balloon with rotational atherectomy, because many of those cases, we all know, your scoring balloon will not even go. One. Second, there will be much high chance of perforation of a scoring balloon, whether it's a cutting balloon or angiosculp or score flex in these cases. And once you have a perforation, balloon rupture happens, that sometime it can give rise to, because they're usually a pinhole, and they can give rise to a dissection, sometimes a rupture and perforation and so. So therefore, I would say that if severely calcific lesion, probably go with the common and well-tested strategy of doing the atherectomy. Rotational, we want to do laser. I know there is a big laser craze in India at present. Everybody wants to do laser, which is okay, but many of the severely calcium laser will not cross also. I have done that. But key is that should you try using a cutting balloon on those cases and compare, get a good results if you could. But I will deter from it. I may use cutting balloon or scoring balloon for that matter as an adjunct rather than use as a primary device. Because primary device has to go through the lesion. It's to use a smaller burr. So you are taking care of the severely calcific lesion, and you can use many of those scoring balloons because you cannot use IVL directly. If IVL can go, to me, that probably, I've been talking to both manufacturer of our Boston Scientific as well as the Shockwave team that do a comparative trial, IVL versus rotational atherectomy, in cases where we think IVL will go in the severely calcified lesion. And nobody wants to do that because IVL is already on the top, and rotational atherectomy, the people are a little concerned that whether we will fail in terms of the device overall outcome. So that's being a theoretical. So severely calcified, go with the small rotational atherectomy burr, then adjunct with cutting balloon, scoring balloon, or high pressure balloon dilatation. To me, I think that's okay, because what it will do, it will crack the interelastic lamina, or your stent expansion will be adequate. So not in severely calcified, I definitely will be deter myself away from using a scoring balloon or a cutting balloon, because once those balloons rupture, can create a trouble. If I had to do something, severely calcific lesion, knowing that the question was whether CAT scan can determine whether it's a superficial or deep calcium, I probably will go with the high pressure balloon first. If your high pressure balloon done the job, expanded, probably you don't need the rotation atherectomy. And we know that.
Yeah.
That in the 1/3 of, we did when the severely calcific lesion in the MACE trial, 2/3 of them, we used the atherectomy only in 33%. Other 67% just did the high pressure balloon dilatation. Scoring and cutting balloon was only in 4-5% of cases. So goal is the lesion expansion. Whichever way technique you do, and that these what algorithm and which we have shown is just to facilitate the ultimate goal, and that is your stent has been fully expanded. Yeah. Yes.
Sir, in spite of so much pre-dilatation preparations, there are many times areas of underexpansion and malapposition, especially in calcific nodules and thick calcium. What can we do to correct these underexpanded stents post-stent? How much we should chase them?
That's a very good point. So remember I said that many times our live cases, you have done everything. You have done the pre-procedural modification, you have done, let's say, the small rotational atherectomy, your high pressure looks good, you put a stent, now you do IVUS. And one area, because there was a calcific nodule, and you still have a lumen not optimal. So question there is, that what you should do further. So do you go another IVL now after the freshly deployed stent? There are some data now that maybe unexpanded stent, you can use a bigger IVL if you use a smaller one begin with, and then try to expand further, but overall, if you got, what I would say, for the circumflex, you got about 4 millimeter lumen. For LED and RCA, you got 5.5 millimeter, you stop there. Because overdoing is risking the vessel perforation. So that's it. There has to be a limit for that. So once you're done all, you leave it there, because overdoing will cause perforation.
Yeah, the forward-looking shockwave is also coming. Like you have a forward shockwave instead of lateral shockwaves. Last comment from Dr. Trev.
Sir,
That
usually
is just to help to deliver your IVL balloons.
Yeah.
put temporary pacemaker for LED rotablation. Recently, we had a case where patient developed severe bradycardia with transient CHP during LED rotablation. So, is there any specific points we should anticipate temporary pacemaker in LED rotablation?
Yeah, very good point. So we actually have in our papers we have published that you have left main and ostial LED. Was that ostial LED case?
No, sir, it's proximal LED.
It was proximal. Okay. So we have seen the same asystole in left main and ostial LEDs. So usually proximal LED did not, but sometime it could happen. So I would not say that there is any factor. Whether long lesion, they're all severely calcified anyway. Maybe there was some intrinsic to that patient which give rise to asystole during that you need a temporary pacemaker. Rare case could happen. So I would say that I don't recall that any of the LAD, non-osteal LAD or left main, develop asystole during rotational atherectomy, but could happen. But there is no predictor for that. But clearly predictors are for the right coronary, dominant right coronary with a long lesion, and left circumflex, long lesion, sometimes osteal LAD and left main. Now, what else you can do, and if you don't want to put a pacemaker, because many of us do the radial, putting a pacemaker is difficult, want to go to the groin, use aminoflin. We published back in 1996-97 that avoid pacemaker by giving 5 milligram per kilogram of aminoflin, 300 milligram with 1 milligram atropine before you started the atherectomy. So with the radial, that cocktail works very well. So 300 milligram IV aminoflin and 1 milligram atropine will be I would say, poor man's temporary pacemaker.
This is my practice. It works uniformly.
Yep.
Because everything related to adenosine and aminophyllin takes care of everything. So you load your patients slowly with aminophyllin, which we used to use about 3 or 4 decades ago for treating bronchial asthma. In fact, the problem nowadays is very difficult to find aminophyllin in the cath lab.
Yeah.
So you have to get it from somewhere from the medicine department, and 250 milligram ampule, which you have to at times give 1.5 ampule. It works like wonders. And to top it up with atropine, I think gives a kind of surety to you that you are unlikely to get into a bradyarrhythmic problems.